Okay, so good afternoon. I'm Dr. Derek Cooney, Medical Director of AMR Central New York, and we're going to go over the memo that was just sent out on ketamine, and this is part one of our ketamine update. So please bear with me, and obviously we're going to field any questions that you can send to the clinical team or to the medical directors, and we'll be happy to get back with you with any answers. And we'll probably include any questions that we have frequently in our part 2 or part 3 of the clinical update on ketamine. So first thing we'd like to do is clarify the details of the memo that we're sending out. So we're going to get started with that. And this memo covers ketamine under the collaborative protocol for behavior, agitated patient, adult, and agitated patient, adolescent, as it applies to ketamine as a standing order. Here in a nutshell, basically we are requiring now under policy a contact to medical control physician to discuss the utilization of ketamine. Okay. So here's what the memo looks like. And as you can see, we've highlighted the key components here, and it affects only ketamine's use under those 2 protocols. And again, it doesn't affect the use of standing order ketamine for any other protocol, and it doesn't keep you from using ketamine. Again, it's that we need a medical control discussion about the utilization of ketamine. Now, for acutely agitated patients who need immediate sedation or chemical restraint for the facilitation of patient care. Again, why are we using chemical restraint? We're using chemical restraint for the facilitation of patient care. It's not for any other reason. Okay? And the goal of chemical restraint is to reach a level of compliance and management that specifically goes along with just enough sedation to allow us to care for the patient, to assess and manage the patient. Now, let's back up for a moment. If an individual is in the field and let's say they are committing some sort of violent act, but there is no belief that they are somehow involved in a medical emergency, so no one believes them to have an acute medical emergency. They're there with law enforcement and they are committing a violent act and therefore are a suspect in a criminal act, they're not a patient. If they're not a patient, then there's no role for us and there's no role for a chemical restraint. So these protocols are specifically for management of patients, agitated patients, and it's for the facilitation of medical care of an agitated patient. Okay? There. That being said, if a patient requires an immediate sedative, the Versed standing order is still standing order, does not require a discussion with a medical control physician. The reason Versed is still standing order is because it's been found in national guidelines and national advisement is that Versed is probably superior to ketamine in the majority of cases where there is a severely agitated adolescent or adult, and in many of these cases it will be a coexisting polysubstance overdose involving most likely a substance that is not, involving a substance that is in fact a substance that's causing some component of the agitation, not just the delirium, but also partly the agitation. So some form of stimulant, and therefore a CNS depressant like Versed is a more ideal sedative to allow us to facilitate care. Therefore, that is still a standing order, and so after physical restraint is utilized, then chemical restraint under standing order with Versed is considered more likely to be preferred. So going through that, the memo does state that you must contact medical control in order to utilize ketamine under those two protocols. Again, that's the behavioral agitated patient adult, behavioral agitated patient adolescent. Here's the adolescent protocol, and as you can see, it does have a paramedic level standing order for ketamine, IV or IM, with 2 milligrams per kilogram up to 250 milligrams IM, or, and there's your standing order for Versed, 0.1 milligram per kilogram up to 5 milligrams IM. So, Versed is still standing order. It does not require you here at AMR Central New York to contact medical control. However, if you're going to want to prefer to use ketamine, again, you'll have to contact medical control. Under medical control considerations, also note that Haldol is still listed there, although we infrequently consider Haldol. You know, from an academic perspective, Haldol is still out there, and in pre-hospital medicine, still to this day, people still do use ketamine, still do use benzodiazepines, still do use atypical antipsychotics like Haldol. But in the current literature reviews and clinical experience, it does appear that benzodiazepines, short, fast-acting benzodiazepines such as Versed, seem to be the preferred medication. And again, used to a goal of compliance only, not to knock the patient out, not to make the patient completely unconscious, not to make the patient flaccid on the stretcher. That is not the purpose of a chemical restraint. There is no room for some sort of chemical retribution to the patient who's kicked one of the emergency responders or harmed an emergency responder or bystander. There's no room for that in a medical response. So again, chemical restraint, the purpose of it is a goal-oriented medical response designed to facilitate the medical care of the patient. And therefore, we are going to use Versed as a standing order, and if ketamine seems to have a specific benefit, we'll contact medical control. All right, here's that, again, the memo reiterating these two protocols now are going to require that call. Here's the adult protocol, and we'll zoom in. And again, here's those common features. Here's a good time to discuss that. Those common features of that acutely agitated, delirious patient, and that's who we're talking about, right? We don't call it excited delirium anymore. That was never really a medical term. That was a forensics term. So we're not using that term. It's not excited delirium. It's the acutely agitated patient, the delirious, acutely agitated patient. Those patients requiring chemical restraint to facilitate their care, we're going to sedate them. Standing order said, medical control call for ketamine when it's appropriate in certain circumstances, and we'll have that discussion. Those calls will be made to the AMR Medical Control line preferentially. You may also call resource, or you may find yourself discussing this with the receiving hospital. Crouse would be an unusual hospital in our system currently to call, simply because by the nature of their particular situation, they do not have the ability to restrain an acutely psychiatrically ill patient. When the situation is specifically a psychiatric, a psycho agitation, that obviously is not the case. If it's a situation where it's a stroke or some other medical condition, obviously they could restrain the patient if they were delirious from that perspective. But in these circumstances, this is more than likely going to be kind of under that more psychiatric type situation. And if it's an acute overdose, intentional or otherwise, we're probably not going to know the full scope. So you're probably more likely going to go to the other area hospitals. But there's no reason to say that they could not necessarily get this call. It's just less likely. But focusing back for a moment on the common features, all of these bullet points describing the acutely agitated patient, these are the features, these are the clinical features. You should be documenting these types of things. What made your patient acutely agitated, delirious and acutely agitated, requiring restraint and then requiring sedation? Those things should be in the chart for you to document and for us to understand why this patient requires sedation to facilitate their medical care. So please keep that in mind as well. And as you can see, in the agitated patient adult protocol is once again demonstrated here that you could, in the standing order category, it has ketamine, 250 milligrams IM, and then also, of course, it has administered ketamine, and then also it had the option here to give midazolam. We're going to use midazolam preferentially, but if you want to use ketamine, simply make that medical control call prior to its use to have that discussion. All right. Now, keep in mind the goal is good patient care, safe patient care. A couple of quick points. Safety, your safety, the safety of the patient and everyone involved is paramount. It's not always easy. It's not always simple to just back away. I know we talk about that all the time, but you need to make an exit. You need to be thinking about your exit when you approach the scene, and we need to be thinking about all of our options when we approach these patients. That would go regardless of what tools you have at your disposal. Now, and that was always the case before we made this policy decision and after. So please keep those things in mind. Call for assistance when you need it and before you need it when possible. If you have any questions about how this relatively minor policy change affects specific clinical scenarios, or if some of this may be news to you, or you've been using this medication in a way that you think this may hinder your clinical practice in a way that you think is not addressed here, please go ahead and contact the clinical team. And as always, reach out to the medical director and the associate medical director whenever you need to. So thank you very much for your time and attention. And as always, thank you so much for what you do here for our community and for AMR of Central New York.